I can't tell you what a pleasure it is for me to see this room so full of nurses from everywhere around the area. We're really delighted to have friends from all the major medical centers and many of the major schools. The Dean of Northeastern, Carol Kenner, is here, and we appreciate her coming and bringing some of her students. The president of New England Regional Black Nurses Association, where did I see Margaret? Is up here, and we're thrilled for her support and her being here today. I never should start mentioning people's names because I know there are many of you in the audience that I am so thrilled are here. But I think this is a wonderful day for us, having so many of you who have come, because, as you know, we started the Pinnacle Lecture Series at the Cornell School of Nursing. This is our second Pinnacle Lecture Series because we really wanted to bring outstanding nurse leaders to come and be able to speak with our community about some of the most important issues that are facing nursing right now. And I can't think of anyone, and this is really true, that it would give me more pleasure to introduce than Linda Burnes Bolton. As you probably know, she's the Vice President and Chief Nursing Officer of Cedars-Sinai Medical Center in Los Angeles. And her area of expertise are numerous, include nursing and patient care outcomes, improving organization performance, quality care, cultural diversity within health professions. But the thing that always really resonates with me is that she has been such a consistent and outstanding leader in nursing. And with many different organizations in many different ways that have all led us, I think, to the thing that we all know her the most for most recently, which is being the co-chair of the Future of Nursing RWJ Institute of Medicine report. Before that, as if being the VP for Nursing and Chief Nursing Officer of Cedars-Sinai, where there are a lot of very famous actors and actresses all the time. But I have controlled myself from asking questions like, what do you know about Charlie Sheen? How? Because I know about HIPAA, and I wouldn't want anybody to think that I didn't know about HIPAA. But aside from that very busy life and being involved with the Institute of Medicine and RWJ, Dr. Burnes Bolton has also been a past president of the American Academy of Nursing and the National Black Nurses Association, and so has really brought expertise from many different groups to the work that she's going to speak with us today about. So she will be sharing today some of her experiences and insight into the IOM report. After her presentation, The Future of Nursing, Human Caring for All, we'll have a few moments to ask her questions before we're going to make sure we get her to the car on time because she's taking a red eye because she has to be in San Diego at some ungodly hour tomorrow morning. And the interesting thing is you can get from the West Coast to the East Coast, but it's not easy to get from the East Coast to the West Coast. This was another thing I just learned. So we want to make sure we're starting on time so we have the most time available. So please join me in welcoming the phenomenal Linda Burnes Bolton.
Well, good afternoon. It's my pleasure to be with you here today. I had the pleasure of speaking throughout the day with students and faculty members at the School of Nursing. It was wonderful to have little dialogues with individuals who are starting their path on a leadership journey and those who've been on the path and just trying to avoid the potholes that sometimes happen with leadership journeys. And so this evening I'm going to be speaking about the work that we've done. Somehow I seem to have lost, there we go. But I'm also going to be speaking about the work that is to come. So when we released the report on October 5th, that's phase one. Phase two, which is the hardest heavy lifting work, is implementing this work. So we'll talk a little bit about that. I'm going to talk about why this work, and it's really about the quest for an equitable patient-centered, safe healthcare system. I say the word patient-centered, I always want to use the word person-centered because that's really what it's about. We interact with persons, But that doggone Institute of Medicine, it has its little rigors. And so as you know from the To Err is Human and the Crossing the Quality Chasm work, they came up with the 6 aims of quality, one of which is patient-centered, so they were not about to let us change. So it's patient-centered it is. Talk about the leadership role in nursing, and then talk a little bit about a model that Dr. Alicia Georges and I developed now some 25 years ago called community collaboration as a framework for healthcare improvement. So 3.1 million nurses in the United States, the largest segment of the health profession. How do you leverage that workforce to be able to meet the objectives set forth in the Affordable Care Act, and the fact that there will be 32 million more individuals who could receive care? The Robert Wood Johnson Foundation, so this was historic. There has never been a study sponsor, that also had a member of staff for the committee. So lots of sponsors for Institute of Medicine studies. Sometimes the sponsors are Congress, other foundations, but this was historic in that a member of the Robert Wood Johnson Foundation was the study director, co-study director. And so we were tasked with producing a report with recommendations, and if you're familiar with the Institute of Medicine, all the recommendations must have sound evidence behind them. They must be able to get through peer review, not just once, but 2 and 3 times in terms of that work, and would represent a blueprint for change at the national, state, and local level. So we envisioned a healthcare delivery system that intentionally promoted wellness. That a shift from our current healthcare delivery system, where the majority of the work occurs in acute care, to one that looked at disease prevention, reliably improved health outcomes, no dog ate my homework, type of health care, get it right the first time, and that it was focused on primary care and knew that it would take a team. Healthcare is a team sport. It takes physicians, nurses, consumers, pharmacists, everyone to be able to make it happen. And so that was our vision, that if we could do that, we believe we would have not only increased access to care, but access to quality care that would be affordable, and we could possibly slow the growth curve that is consuming the American healthcare dollar today. The result was this publication. We released the hardback of this publication a month ago. So if you haven't received it, you can go to the National Academy of Sciences website, and you can download it, all 600 pages. Or you can purchase it. But the Future of Nursing, Leading Change, Advancing Health. Why that title? Because it says what we wanted to do. The whole point of this work was to advance health in our country. That was to do it. Leadership is what makes it happen. Everything else is effect. So if you want healthcare delivery system change, you must have leadership. If you want any type of social change, you must have leadership. And we believe that the future of nursing was about leadership, and that leadership is practiced daily by a variety of individuals. It does not have to be someone who's titled as a leader. There were 4 key messages. The first one is nursing should practice to the full extent of their education and training. We saw multiple examples, multiple wonderful examples that you will see in the publication of where it was happening across our country, but not everywhere, where nurses were leading change, where once you had removed the scope of practice barriers, they were able to provide access to care to more individuals and have it be more reliable, and by the way, it costs a heck of a lot less. And so this, how do you scale up, is the work of the implementation committee. Key message number 2 is that nurses should have higher levels of education and training through an improved education system that promotes academic progression, seamless academic progression. Today, only 30% of the nurses who graduate initially pre-licensure with an associate degree go on to obtain a bachelor's or a master's degree. And without scaling up some of the wonderful examples that we saw of academic progression across the country, they're great examples, we will not be able to transform nursing. So we're the largest of the health professions, but we're the least qualified in terms of preparation. And we need to change that. We also need to have effective transitions into practice because none of the other health professions, the major ones, ever think about practicing without some type of residency. Pharmacists have residencies, physical therapists have residencies, not just physicians have residencies. And that we need to double the number of individuals prepared at the doctorate school level. Key message number 3 is that nurses should be full partners with physicians and other health professionals in redesigning the healthcare system of the United States. Full partnerships. That means that at all levels that nurses should stand up to assume responsibility for the delivery of quality health care, and that must take on the notion of 200% accountability. I'm going to be 100% accountable for my practice, but guess what? Because I'm really about doing good, I'm going to be accountable for someone else's practice. So if I see someone else practicing in such a way that might cause harm to the patients, I'm going to stand up and lead and do that work. Key message number 4 is that we need effective workforce planning and policy making to make better decisions about the deployment of the workforce. There's a lot we don't know. And although the Healthcare Workforce Commission was commissioned, it wasn't funded, but we did give some directions to them in case they get funded. We're not waiting for that because the good news is Dr. Mary Wakefield at HRSA is doing some of this work, as well as the Department of Labor has taken it up. And a key is this last sentence here. A priority should be placed on the systematic monitoring of the supply of healthcare workforce across the professions. Systematic versus the episodic. So for example, we think that the National Nursing Sample Survey being fielded every 4 years won't get it done. The changes that are happening in terms of demand for healthcare are so rapid that we need another way to be able to get that data, maybe using state boards of nursing data. So the nurse's role in this vision, as I see it, is one about leadership, one about stewardship, and one about circle calling. So leadership means just that you will stand up and lead. You need to have the knowledge and experience and skills to be able to do that, but you're willing to assume that leadership role. Stewardship involves being the guardian of resources and making sure that the allocation of those resources are most appropriate for the work that you want to have done. And then circle calling is about Christina Baldwin's work, and that whenever there were solutions, wherever there were problems in a community or a nation, and you wanted to resolve those problems, you called diverse voices to the table. And whether they sit in a circle or a square doesn't matter. But they are diverse voices coming together because the solution lies in being inclusive of everyone and listening to everyone and then acting as one team. So, nurses must lead. This almost was the title of the program, title of the book, Nurses Must Lead. It's required at all levels. Collaborative practice is essential. If we're going to get to those 6 aims of the Institute of Medicine, of safe, equitable, reliable, efficient, and affordable patient-centered care, we must be better educated, we must change the scope of practice, and we must lead. So these have been the implications of what we need to do. First, increasing the diversity of the nursing population is essential. The 2008 National Sample Survey said that we hadn't made much progress of that. Increasing the diversity of nurses would earn doctorates. We haven't made significant progress on that. We haven't increased the diversity of the nursing faculty. And we need to engage ethnic and racially diverse consumers in design and implementing healthcare services that are patient-centered. I didn't say they were culturally competent. If you leave without one thing from me, know that this African-American nurse cannot be possibly culturally competent in all the cultures that exist in the world. Neither could either of you. And so it's not about cultural competency as it is about being inclusive and about being person-centered and finding out for people what they believe to be relevant for them in the delivery of health care. So this is the National Black Nurses Association Community Collaboration Model. It's based on a belief that the core value of nursing is human caring. So if you believe that you believe in that core value of human caring, you do everything you can to be able to acquire the resources, to work together as a team, to be person-centered, to deliver care that is a benefit to humans. That it calls for the engagement of diverse populations, organizations, and individuals to be able to design culturally relevant, equitable patient care services. We believe that the Initiative for the Future Nurse vision is an example of this model in action, and that nurses as leaders can help to remove the barriers to equitable healthcare services. If you remember other IOM reports that talks about healthcare disparities, and what was the barriers that sort of kept us from getting to equitable health services, it's this notion of not taking people where they are, including them, and providing human caring based on their needs versus some stereotype that you might have. It says that we value humans, and that is the ability to assist others, the ability to produce relevant services for individuals, the capacity for creation, that there is bestowed in all humans is this capacity for creation. We just need to tap into it. The capacity for change to lead improvement, and that we keep in mind that human caring is core to our mission. These are other parts of the collaboration model. First, value, diversity as a pathway to wholeness. And if you just think about that for a second, there's no way possible that any one human being could have all knowledge, right? I know there's some people who walk around and think they have all knowledge, but they really don't, okay? But if diversity is a pathway to wholeness says if you bring multiple, you're inclusive, you bring multiple people to the table, wow, you just took the ability to be creative, the ability to problem solve, and you just multiplied it times 5 or 10 or 1,000. Value in the innovation and design and of healthcare delivery, and commitment to doing public good. So organizations that exist for mutual good, they have to exist. The essence of the community collaboration model is that it is a model based on public good, and that professional societies should be organized in such a way to do that public good. So let's talk about the diversity as a pathway to wholeness. It is a core value with roles and responsibilities at institutional levels, and you can track that. It is the work of human caring that requires respect for all. It is making sure that education programs across the organizations integrate diversity in their approaches to learning and teaching. And if they're not, then they're not preparing the next level of healthcare professions that we need. We need it to be within the curriculum, not a class that you go take at the end of your 2 years or 4 years or 6 years. It has to be integrated across the curriculum. So this is just, when we talk about diversity and we asked the individual, and this was a poll from 2000, percentage of people who think race or ethnicity presents barriers to receiving quality health care. And you take a look at it. Everyone thinks that it does. You didn't see a minority. While whites are 48%, you don't see anyone that doesn't think that is an issue. So it is an issue to be addressed. This collaboration model utilizes consumers and ethnic nursing organizations in efforts to improve utilization of primary care services. That's the #1 thrust. How do we help people to be able to navigate the healthcare delivery system and to increase their utilization of primary care services? We use cultural reference in the design and delivery of healthcare services. We wouldn't think about putting up a building without going and talking to the people who are going to be in that building, okay? And so that's true in the design of healthcare delivery systems. It integrates diversity, education, and curricula as opposed to a single course, and it employs stewards and leaders to advance health and lead change that are from the consumer perspective. An example, the Harambee Center. This is one of our Raise the Voice campaign designated centers. Raise the Voice is a campaign of the American Academy of Nursing. And this center, which is community-based, and is an academic nursing center that's staffed by nurse practitioners, family practice physicians, students, and community workers. They begin their work by first going and speaking to the people. What's important to you. Harambe means community. And what was important to those people is that the center be theirs. You know, it's not the School of Nursing, it's theirs. And that they be a part of it. And what were some of the outcomes? They increased access to care for underserved population. Every individual in that community now has a health care home, not a medical home, a health care home. They decreased ED visits and hospital readmission rates. They improved preventive health services. They improved hemoglobin A1C levels, improved functional status, decreased missed school days and worker sick days, and achieved those outcomes at 15% less in terms of the Medicaid budget in that state. This was replicated in the states of Pennsylvania with the 3 centers that are there, and it's been replicated across the United States. The future of nursing work says, how do we scale it? How do we put it across every state and every community? So in diversity of education, you integrate the care of diverse populations, as I've talked about, and you provide experiences in diverse settings. The way to learn about what is relevant and what is appropriate to people is to get out there and be among the people. Now there's a thought, okay? You must be among the people if you're going to learn from the people. And you have to learn from the people to be able to provide culturally relevant care. So we need to get cultural reference emerging from education service community. We need senseis. Senseis are those individuals who understand that to be a great leader, you must be a great teacher and a great learner. You walk between those two worlds. You're a great teacher and you're a great learner. And if you're not a sensei, you can't possibly try to design healthcare delivery systems because you're not listening. You're not listening to what the people want. So I believe that this journey that we're on and the work of this commission has to be, requires leadership that requires science and requires embracing new ways of knowing, stewardship, and action leadership. All of those are about the work that we're going to need to advance the future of nursing. Action leaders are part of that. Action leadership is more transformational than it is inspirational. You can be great, you can be an inspired leader, but if you can't make it happen, then that's not the type of leadership we're looking for. We're looking for transformational leaders that are committed to changing society and are focused and value sustained efforts over time. They value preparation. So if I said I wanted to go in, and I'll give you an example from our first initiation of the community collaboration model that was done in Los Angeles, where we wanted to do something about the high infant mortality rate among African American and Hispanic young women who were abusers of cocaine. Okay, and could this happen? Well, we had to first go out there and find out about the population. And we had to find out what's important to them and what would trigger their willingness to change behavior. Then we had to seek evidence from many sources, so we started a program called Great Beginnings. And in that Great Beginnings program, we invited individuals in, those young folks in, and helped them to understand the possibilities of a brighter future. We then went out and got the public relations firms that actually won a Clio as a result of this work, about how we can use that asset. You know, today it would be social networking. But, you know, back then when we designed the models in the early 90s, there was not as much social networking as this. So we used radio stations and televisions and billboards to get the messages across about having pictures of babies with all kinds of tubes coming out of them, you know, weighing 800 grams. And that visual cue hitting that teenager right smack between the eyes. You know, it was a community collaboration model. We went out, we got the folks who would benefit, we got people who could help us, we got nurses, doctors, nutritionists, social workers, and we ran that campaign successfully and decreased infant mortality rate in the county of Los Angeles among those two groups by 20% over that 5-year period. That's the power of collaboration. That's when you bring in diverse voices to co-create the work that change you want to see. So at the time that we did this work, it was Senator Barack Obama. But now there are all kinds of individuals who have been doing this wonderful work that we stand on. The steward's role is this holders of the truth as defined by the collective. It's not truth as defined by you. So if you're going to do this work of advancing health, You have to do it in collaboration with those who would benefit from it. Leaving people out and designing your own systems will result in the same type of healthcare delivery system that we have today. You've got to break that model, that you have all the knowledge about how to design healthcare delivery systems. So examples of stewardships include Dr. Martin Luther King, Sojourner Truth. Florence Nightingale was a true steward, but she also was an action leader, and Rosa Parks. It takes innovation. So we saw so much innovation across the nation. Do take time to read the appendix, where you have all these wonderful examples of work being done, led by nursing in full partnership with others, that have helped to move this work forward and actually obtain outcomes in small rural communities, in large urban centers. It didn't matter the size or the place. The first thing was someone saying, I will call the circle. I will invite the diverse voices in. The second is engaging individuals. The third is bringing in both public health and private partnerships. And then the fourth is launching it with the idea that it will take a sustained effort. So circle calling is this ancient wisdom that draws upon the knowledge of many and the visions of the collective. As I said, solutions lie in the spirit of discussion. This is Christina Baldwin's work. If you have not read Christina Baldwin's work, I encourage you to do so. So what's the next steps? Well, you must embrace this vision first. You have to have a shared vision. If you talk about things in terms of a project, if we had gone into this work with just it being a project, it would not have legs. You got to have a shared dream. And we have this shared dream that nurses, not for the sake of promoting nursing, but for the sake of improving the nation's health, that this large segment can help to get there. So that's our shared dream, that we must all be circle callers, and invite in people, adopting human caring as a key strategy, and then support the recommendations. It takes this entire face of nursing, and with consumers. Why is the program for implementation at the Center for Champion Nursing in America? Because it's at AARP, because AARP is the largest consumer group. So, as one of your fellow New Englanders has said, Dr. Don Berwick, often, nothing about me without me, right? Nothing about me without me. How can you say you want to improve the nation's health without including the individuals who would benefit from that? And so in the implementation committee, there is lots of consumers. There are only 4 nurses. Just as in the Future of Nursing committee, there was not all nurses, because work is not about all of nursing. It's about the larger body of work that requires wisdom, to use information gathered from data and observations to obtain knowledge to inform clinical and operation decisions, to understand how X acts and reacts to develop Y about the human condition, and the wisdom to ask the right questions within diverse contextual situations, because the questions are different. They are different, And to learn how to ask the diverse questions, you must invite people in and help them to form. They will help you form the question. So I hope I want to leave you with some healing wisdom about this work, and that this is from an old African proverb that says, "May those from under our feet breathe the warmth of community unto us, so that the peace we seek mounts our bodies and sits on the chairs of our hearts, sprinkling love and joy around us all." That's the healing wisdom. That's the wisdom that nursing has embraced for many centuries. And sometimes we lose sight of that. That's our real work. Our real work is human caring. I had some great opportunities to talk to some students today who said they started off as pre-med students, and they got degrees in sociology or biology, and they had a chance to go in their program work in some area, and they got to talk to a nurse, and they said, "I got to be one of those." That experience that when you get it, that your ability to use all your knowledge and skills, and the fact that you must continue with that knowledge and skill growth, to help other individuals and to advance the work of human caring can be very rewarding, but it's a journey. It's a journey. It's a leadership journey. And so we have to have healing wisdom on that leadership journey. And with that, I'm ready to take questions. Mm-hmm.
Our healthcare system has always been based on an acute model. It's never been based on a preventative model. I don't think it's any different now than when I was in school in the 60s. Even our Medicare system for people that are 65 and older is based on only an acute model. When do we get to the point where we can get to the children and young adults, and we have to educate them to live better lives, because that's the change. It's like learning. It's very difficult to change a socioeconomic background, but if you start with the children when they're young and work with them as they're growing, work with their parents, and even now with the new program for healthcare for all, what are we doing for those people that are in communities that still won't have access to healthcare? Do we need to look at that community-based program in those rural communities so that they can get help?
So the good news about the Affordable Care Act as it was passed, and I'm emphasize that, as it was passed, because there might be some tweaks to it over the next 2 to 3 years, depending on who's in Congress. All right? But as it's passed, it actually begins to do that work. So it pays for, it takes money away, and it's the only way to say it, when you do zero-sum game work. It takes money away from acute care hospitals and from physicians, and it says that we're going to reinvest those dollars into primary care, and primary care that has intentional prevention and wellness programs. And by the way, hospital, if you want to get in the game, you must become part of what is called accountable care organizations, where you get paid more, not for how many times you admit the patient, but for keeping the patient out of the hospital and for actually keeping them well. So that's the foundational change, and that we believe is what's going to make a difference. The second part of that, it begins this year, in July of this year, saying that, to pay for it, if you remember the debates that were going on last year about it, how in the heck are we going to pay for 32 million more people having access to care? And the way it was positioned is to get rid of the waste. And so part of the waste is readmissions to hospitals. And when we looked at some of the programs, many of which are in the publication, where nurses had successfully reduced the hospital readmission rates, not just in heart failure, because that's the one that's been promoted the most, but also in community-acquired pneumonia, also in terms of sepsis and other types of things. It was stepping back, I call it stepping back, to take nurses who, right now nurses in the nursing profession is 65% in acute care hospitals and 35% outside of acute care hospital, and flip it. If you have the knowledge and the expertise of nurses working with others out there in the community, you actually could do more primary care, chronic disease management, and wellness. But you have to have incentives to do that. And that's what's embedded in the 2013 and 2014 portions of the bill. In the 2012, I'm talking fiscal year 12, okay? Fiscal year for the Fed starts October 1 this year. So July of this year is what is called base year for hospital-acquired conditions. And so to pay for this work, if you fall below the median in terms of hospital-acquired conditions, in terms of the volume of them that happens in your institution, you will get paid less as a hospital, and we'll see if it makes it. In 2014, physicians were supposed to be affected. So if a physician had a high readmit rate of XYZ. So they're in the bill is that what we call infrastructure building to try to begin to turn the triangle, where right now most of healthcare service resources are at the acute care level, and at the tip is as wellness and then primary care. We'll see. Without the incentives, so if you look at Kaiser, right? What makes that integrated healthcare delivery system work? They put a large proportion on primary care and health, and they eliminate barriers like co-pays to medications and other type of things. And now they have all these programs to help you thrive because they figured it out. If I keep my per member per month expenses down, okay, because per member per month expenses is how you look at it, and I keep people out of hospitals. Guess what? I'll have more money to do some of this wellness work. And there have been other examples of that. Geisinger Clinic, Cleveland Clinic, a few others that have done that. But that hasn't been scaled around the country. So as long as we have a fee-for-service model, backbone of the American healthcare delivery system, fee-for-service model, we will have disincentives to doing this intentional wellness. So gradually over time, looking at how do we begin to turn that is the work that has to be done. And that's monumental work that will have to be done. We'll see if the insurance companies will play. Now, they played a little bit in terms of the healthcare reform bill, because otherwise they would put other provisions in there. Just putting in the provision about allowing you to keep your adult child on your system longer costs a whole lot of money. But if you kept them there, there was enough little studies that showed they actually stayed out of hospitals, which is, after all, the place where most of the money is expended, besides end-of-life care. And some interesting things coming out in relationship to end-of-life care. I'm so happy to see more acute care institutions using palliative care nurse practitioners as a part of their palliative care team. And they've been extremely effective. I have 3 of them, and effective in when you come in the door, you have to have a decision with that family, okay? Now, hopefully you had that discussion before you got in the door, but if you didn't, within 12 hours of being admitted to my place, you're going to have a discussion about really what it is that you want to do. And we put limitations on who can get into the ICU. So if it doesn't look like we're going to be able to sustain life, you're not going into our ICU. And having a group of clinicians that is made up of nurse practitioners and board-certified palliative care team members and social workers to support that. Now, that's great that we can do that because I'm a large academic medical center, but how do we scale that across the United States? Well, might be if we could get more palliative care nurse practitioners. Do you know that there are less than 25 palliative care programs for physicians? So, but we have a greater chance of getting more palliative care nurse practitioners, not replacing physicians, working in collaboration with physicians. That's just one example. Yes?
Where does the insurance company factor in? Are they in your circle when you...
They have to be. They have to be, whether we like it or not, they must be. So we did get some people at the table. Some of the, and the good news is we have a friend in terms of that who's been willing to work with us. And as a part of putting these recommendations together, we have to do a litmus test, if you will. And so we went and talked to the insurance companies. They have shareholders, So I don't think it'll happen in my lifetime. When I was 22, I thought it would happen in my lifetime. No, it's not going to happen in my lifetime in terms of universal care. So there's always going to be insurance companies. So you just have to answer that WIFM question, what's in it for me? A question for them. And it's about costs. They listen to that costs because their costs have gone up. Their actual costs, not their charges. Their actual costs have gone up. and the ability to lower costs gets them to the table. Yes?
Have you been able to bring the legal team onto your circle to try and address these lawsuits and the kind of ways that happens for society?
So part of our recommendations have been some work that we took to the Department of Justice. Now, that's a tricky thing to take to the Department of Justice because it's, what is that, the statement, it's like the fox watching the hen house. You're talking about lawyers watching lawyers. But several states, including this state, and others, have begun to put limitation, and tort reform in place. And so we have, in California, we have a MICRA, called the MICRA. It doesn't matter what happens to you, the limitation is $250,000 for any pain and suffering. That took a lot of wind out of the sails of attorneys who would go after the pain and suffering, not the real injury, but the pain and suffering piece, to be able to up the price, up the fees. We're beginning to see some of that happen across the states, and to tell you who's leading that work is consumers. And that's the right ones to lead it, not physicians or hospitals, or the lawyers, the people who would benefit from it. The first piece is make sure that everyone, provides defect-free health care. And so for consumers to know, some people are gun shy about the fact that everything is available. My gynecologist says to me, "I'm so glad I'm seeing you instead of one of my other patients." I said, "Why, Dolores?" She says, "Because they go onto the internet and they find everything that's wrong with them, and they come into me and they say, 'Here, fix it.'" So the internet kind of has its positives and good and its negative sides of it. But consumers are finding out what works and what doesn't work by going in that, and they're demanding something different. Now, a good example is looking at the how many individuals who have heart disease and what are the differences in who has access to the valve replacements that are done in cath labs versus the valve replacements that are done in an open general care hospital. Open OR. Valve replacements done in a cath lab, you're home in 1 day or a day and a half. If you get a valve replacement in an OR, you're going to go to the ICU. You're going to be out of that ICU, going to be there at least 3 to 4 days, and it's going to cost 10 times as much as that valve replacement that you do in the cath lab. The real key, so people can argue those 2 points, the real thing is go downstream and figure out why they're getting the valve replacements, not spend so much money on whether one is better than the other. But you need to do that research, but you really need to find out why people's valves failing, and what can we do to do that. And we need more research on that downstream piece that we haven't. So if you look at the research priorities that came out of the report, it's calling for more of that we need more of the research community to not just look at what works in terms of comparative effectiveness research, but comparative effectiveness research is really aimed at keeping people from having to use those last resorts in terms of interventions. Yes.
Can the community collaboration model work with insurance companies in Switzerland and without a single payer system?
It has in certain communities. So you take the state of Minnesota. I love the state of Minnesota. Now, I'm not from the state of Minnesota, but, they did it. They have insurance companies, but, in terms of the play there, they're the first state that truly has the ability to say, we're walking together to improve our state's health. And they've been extremely successful. How do you take that model and scale it? Okay, including even with their Native American population. So people said first that, it was all of those, people from Sweden and that type of thing. I said, no, it's not. They included their Native American population. So Minnesota is one of the aligning forces for quality states of the Robert Wood Johnson Foundation Initiative, which has 14 models that we're trying to replicate across the United States that says we can call the circle. So that's exactly what those aligning forces have done. They've done phenomenal work across the United States. There's a Boston collaborative here, by the way, that I was speaking to someone earlier about. Yes.
Just based on your experience of building collaboration with physicians that's truly invested in improving the healthcare with removing some of the turf battles over changing practice, over practice, and stuff like that. Any suggestion? I don't know if I'm looking for the right questions to ask, but really getting investment from physician leaders in doing some of the work that we need to do.
You won't bring all of them on, so you have to do this in incremental change ways. So the first, which is why the report primarily addresses tackling primary care first. Now, you say, well, why tackle primary care first? That's where the greatest demand is in terms of healthcare changes, is in primary care. Second, that's where the least fight is, because there's not many physicians in primary care. Okay, no, just you have to be smart about this. If we had taken on orthopedic surgery, we're not preparing individuals, someone else other than a surgeon, to do orthopedic surgery, and we'd have had a big fight on our hands. But in terms of what the demand for healthcare services are, it's in primary care. So that's why you will see, you can go on Wall Street Journal. In November, there were several articles in Personal Journal where physicians attesting to their wonderful collaborative work with nurses and what they've been able to change to having a true collaborative practice model. And it was in the New England Journal of Medicine, a great piece there that was done by Bill Novelli and Donna Shalala, And so physician groups are coming out and saying we can do this, right? But it's not, we don't expect the American College of Surgeons to come out and do this, nor the American College of Neurosurgeons, or the fellows in the American Academy of Neurology to come out and do it. But for the large majority, now one surprise we had were the pediatricians. Now you guys know that nurse practitioners started there, right? It really started in pediatrics. We were a little shocked that they came out against this study. Some of that is just economics. It's just economics, Yes.
Earlier you were discussing the plans to create incentives for reducing hospitalizations and that sort of thing. I'm just curious how that prevents, I have read a little bit about how the pay for performance really work because it drove practitioners and healthcare personnel away from areas which really need the most effective area of primary care. So how do you balance preventing bad outcomes with delivering care in areas where it's most needed?
You have to incentivize the practitioners to stay in the areas by creating new roles and things. So the transitional care model, which just exploded the opportunity for nurses to get back to work that they used to do, which is in community and home, and paying them for doing that work in community and home. And so that's actually embedded in the Affordable Care Act. So, always, first thing, you got to create the incentives. And so, if you're part of a group practice, or you want to say, the rules for affordable care, accountable care organizations just got released a week and a half ago. So finally, they're out. You could be a part of an ACO. Then you can get directly reimbursed for doing the work that keeps them in their home. And without that, it wasn't going to work. Yes?
So one of the big things about being a leader is being able to take foresight, knowing what your problems are going to be when you're trying to implement all of these different things, because problems are going to arise.
Mm-hmm.
So what are some of the big problems that you see that could possibly arise? Like I was thinking from the physician standpoint, if they're going to get penalized if they take on really sick patients because then they can get hospitalized, does that leave then the nurse practitioners and nursing in general to take care of those patients, and then our numbers start to look bad?
Mm-hmm.
So what's going to be done to sort of to help that so that the sick patients are still getting the care that they need, and that nursing and physicians still aren't at this battle between each other of who
Well, there's two things. One, the first part of the Affordable Care Act doesn't affect physicians yet. So it hits the hospitals. And so which is why it was, saying that we need to replicate the models that work like in Cleveland Clinic and Kaiser, where there is skin in the game, if you will, for the doctors too, to keep the patients well. Because where you get the reimbursement is going to go is to delivering that care in your office or your clinic. So they're not going to walk away from the patients. It's about how do you get better care done there right the first time. And that's what the accountable care organization model is all about. So there are 62 measures that in the accountable care organization. Most of those measures, the large proportion of those measures, are ambulatory. There's a portion that's hospitals, 16 of the 62 are hospitals, but the rest of them are ambulatory. So it is in the physician's best interest to care for that population. And you can't get just an all-well pool, because that's not what's here in the United States. Everyone has something going on. But your degree to share in the income that will come in from the feds is that you move people along. You may not get them permanently there, but that you're moving people along. And they're tracking that over time using these 62 measures. Like in diabetes, I can't remember, there's something like 8 or 10. It's not just, hemoglobin 1C. There's 8 or 10 things that you have to do. Behind those 8 or 10, there's strong evidence that if you do these things, you actually are going to make a difference in terms of individuals with diabetes. Yes?
What do you think is going to happen with Congress, the Affordable Care Act, and the budget in the next several months? You have an hour to answer.
Well, the only good news is there's the Senate. The Congress is split. The House can get things through, but the Senate has to pass it too. And that first volley, trying to repeal it, didn't work, and it still doesn't work. The real issue is what happens in 2012. So there's provisions that go into effect July of this year, then there's other provisions that go into effect the first part of 12, and then you start looking at fiscal year 13, which starts October 2012, and it all depends on who's in the White House and who's in Congress in terms of some of the provisions. What I think is that the large portions that, in terms of accountability, will stick to a certain extent because there's savings associated with that. Reducing readmit rates, for example, billions of dollars. So, that'll stick. But whether or not some of the other provisions, particularly about increasing access to primary care services, what's not in the bill, and we met with Sebelius about that more than one time, is that in terms of direct payment for primary care services, they included PAs, but they didn't include NPs. And when we asked Congressman Waxman's staff about that, what was that about? They said they couldn't sell it because there's so many more NPs that what they anticipated the cost would be, not looking at the return on investment, would be great. So we're not going to get that through right now. It's going to take a while. So it's all those kinds. It's a lot of ifs, ands, and buts. I don't have a crystal ball, and I don't think there's anyone in this world that has one about it. All you can do is try to look at the provisions that are going to be in each of the upcoming fiscal years and try to capitalize on each of them and get those under your belt with some experience under your belt about that. Releasing these 62 measures on accountable care organizations go a long way because that at least starts, and you can have some preliminary, tests of change with institutions that are going to do this work so that by January 2012 you have some data about does it work or doesn't work. One more question. We're all the way over here. You? Yeah?
Given the hats that you wear, one in a major academic medical center and the other work with the future of nursing, can you talk
Well, as you know, acute care hospitals make up the most costs, right, besides physicians. But they discharge patients to nursing homes or back to physicians' office practices. The whole thing about ACO is that you're going to share in you can share in the income, but you're going to share in the expense. And so if you want to get that nursing home to, do more about preventing pressure ulcers and putting in patients in restraints and falls, you hold, something over their head called income. And if you want to get that physician offices to, start making sure that that patient gets their pneumococcal vaccination and is managing their diabetes not with level 1 drugs, but with level 2 drugs that have less side effects and are more likely to be accepted by the patient, you hold something over their head called income. That's the whole thing about accountable care organizations. Because hospitals receive the most, that's why they're the number one player. But if that patient gets readmitted, the hospital takes the hit. So there is incentives among all of those players, including the home care provider, the durable medical equipment provider. There's incentives all along that continuum for everyone to work together. Thank you all very much.